ಇಲ್ಲಿಂದ ಉತ್ತರದಾಗ
That's there. We wait for some more time or start?
Bharti, what do you suggest? Should we start or you want to wait for some more time?
Just 2 minutes more. Sorry,
Okay,
ma'am came, so we can start also. Because Dr. Sakila is also supposed to join. She is joining right now.
Okay.
Bharti is the moderator.
Yes, ma'am. Good afternoon.
Good afternoon.
2 more minutes, if we can.
Maybe
Yeah, sure.
05 will start.
We will not wait further. We will start.
Okay.
Okay.
So good afternoon, everybody. Bharti, you want to start?
No, ma'am. Please, ma'am.
So I think I want to welcome everyone on behalf of MSSRF to the second of the 2 webinars that we're having on malnutrition in Indian tribal children. And yesterday, the focus was more on the causation and the data on from the surveys and so on. And today it's going to be more on the interventions. And we're going to have Dr. Bharti Sahu, who's the lead of Agriculture, Health and Nutrition Program, actually to moderate today's discussion. And we've got 2 excellent speakers lined up as well, Dr. Vandana Prasad and Ms. Annapurna Kundu. So the idea is that we've understood that this is a big problem and a priority for the country and for all of us who work in this field. How are we going to find a solution to address tribal malnutrition across the country and learn from perhaps experiences on the ground, but perhaps also what are the gaps still, if there are still gaps in knowledge, maybe there's more of implementation research that's needed, as well as what are the policy interventions that we could advocate for, and any other ideas that come up during this webinar that MSSRF could take up along with other like-minded partners or work together towards addressing these severe malnutrition issues that we see around us. So I think with those few words, I'll hand over to you, Bharti, to moderate this afternoon's discussion.
Okay, ma'am. Yes, thank you, ma'am. And I again welcome everyone to this second webinar of this 2-part series. I'm Dr. Bharti Sahu, and yes, I'm the moderator for this webinar. And my co-chair is Dr. Ashok Felodi. And before going to begin this webinar, I have few housekeeping points that we have totally 2 hours and each speaker will have 30 minutes. I request the audience to post their questions on the chat. After each speaker, I'll summarize the key points. There will be then question and answer session. And in the interest of time, first 5 questions will be allowed and will be taken to answer. And after we finish the question and answer session, both the speakers, after they finish all the session, we will have experience sharing session from 3 community level champions of different tribal regions. So now, I would say I would like to say about the first day. In the first day, as already Dr. Shomya mentioned, that it was regarding causation of malnutrition, and today's the webinar will be the interventions, which is regarding to reduce malnutrition in Indian tribal children. And MS Swaminathan, since its inception, is very much focused to work on these areas. So our maximum areas we always involved as research, community-based interventions to promote food security, building capacity at the community level, and demonstrating models and policy advocacy. Now, to discuss all this more, we have two eminent speakers. So we will definitely like to listen more from them. And those are the two areas that how one of our speaker will highlight on the evidence-based experiences, and the second speaker will highlight on how Odisha state government, particularly the Department of Women and Child Development, is working in this regard. So, I would just like to give a brief intro about our first speaker, Dr. Vandana Prasad, who is founding secretary and technical advisor of Public Health Resource Society, New Delhi. She has done her MBBS and MPH, and also MRCP from pediatrics. Is basically a community pediatrician and public health professional. She has been engaged with social sector for the last 30 years. Her main experience and expertise is in the area of malnutrition, healthy system strengthening, and child rights, and she has many publications in this regard. Now, at present also, he is leading models for community-based management of malnutrition and participatory learning exercises with women groups in tribal and rural communities, along with research and documentation as part of her organizational work. She has been a joint national convener of People's Health Movement of India, that is Jan Swasthya Abhiyan, and an active member of Rights to Food campaign. Dr. Prasad has also served to the Government of India as member in the Child Health Section and National Commission for Protection of Child Rights, and is basically an advisor to the community process in the National Health Systems Resource Center. And her Dr. Vandana's talk today, Dr. Vandana's talk is experiences in addressing young child malnutrition among tribal communities. And our second speaker is Miss Annapurna Kundu, who is at present District Social Welfare Officer of Koraput District in the Women and Child Development Department of Government of Odisha. She has 36 years of experience in the field of women empowerment through Mission Shakti, and a nutrition assessment for pregnant women, lactating mothers and children through supplementary nutrition program. And she has also experience in imparting nutrition and health education sessions to Anganwadi workers in the field. And her topic is role of the state in addressing young child malnutrition among tribal children. Now I'm handing this session and requesting Dr. Vandana Prasad to carry out the topic. Thank you. Dr. Vandana.
Thank you so much to MSSRF and to Bharti for inviting me to talk about something that obviously has been something that I've been working on for just decades and very close to my heart and very close to the action that we've been doing. Before I start, I just want to acknowledge the presence of one of our senior program officers who's also located in Odisha, Shanavaz, and he has been helping me put some photographs together and so on. He's here also. He's handling a lot of the MIS work that we do. Apart from all of program. So let me just share my screen and get started. Yeah. So, I mean, the ask for the webinar is really quite intense and large. I mean, and there's really a lot to talk about. I'll just try to condense some things in this coming half an hour so that we get kind of a sense of, the domain and what the areas are which require more intense work, what are the strategic things that can be done in the near future to make a distinct difference and so on. So I'm going to try and not provide comprehensively a treatise on everything that we've done to address young child malnutrition among tribal communities, because as I said, about 10 years we've been working very intensely in tribal areas. So, but kind of make a few points within that are more focused. So, the slide is not moving down. Yeah, I think just very quickly about schemes and gaps, because the subsequent speaker may also reflect on these, but it's very, very important because, in PHRS and PHRN, what we believe is that we're not there just for implementation. We're not there to duplicate government efforts. We believe that government is going to be the harbinger of services and entitlements to everybody in this country. And yet there are critical gaps perhaps that need to be filled. There are some new things that need to be demonstrated. So that's really the role of civil society organizations. So we take it upon ourselves not to replicate, duplicate, create parallels, but to also provide kind of strong information, solid information on what more needs to be done on the basis of analysis of the schemes and programs themselves, and also on the basis of the experience that we've had on the ground. Now, these are mota moti, I mean, these are the big schemes that really impact child health and nutrition. And as we know, nutrition is not only about food and food security, it's also equally about child health. So these are the main things that we encounter when we're working on child health and nutrition. And they all have some common typology of gaps also. And they also have very specific gaps. Now, I'm sorry that, I mean, I could spend the whole day talking about the ICDS, because really that's been one of the platforms that we've been trying to engage with forever, and we've been trying to improve, and many things have happened also as a result of that engagement. So, but some things I will say specifically as I go along. Now, I think one across the board, it's very, very important. These are new learnings that for instance, that the first 1,000 days are critical to child malnutrition. So, yet within our schemes and programs, the under threes have remained quite absent in some sense, or the focus has not been so much on under threes, and there's the reason for that. The reason is linked to gender, it's linked to the mother-child diet, the general invisibility of this child. A little baby is basically in the household, not seen in public spaces, not seen in schools, and so on and so forth. So there's a reason for that, but it's a fact. So malnutrition happens to be there, but it's also the gap area in most schemes and programs. So underserved under threes is a very important thing to figure out. Now, we know that, I mean, most of us who are working on malnutrition, we're familiar with the UNICEF framework of causation of or the determinants of malnutrition. Care as a determinant has typically not been given the priority that it needs to happen, because we know that children under 3 in particular need adult caregivers who are sensitive, who are informed, so on and so forth. And everything has to happen as a result of the work of that caregiver. So whether it's health, whether it's safety and protection, whether it is nutrition, everything has to come in an environment of care. Now, have we analyzed does that environment of care exist or not? And I think that many of our interventions are very short on understanding that. These are all complex and difficult things to actually work on. But, having said that, this is time that, we really focus on care. So this is one very important thing. Poor focus on specifics. This is extraordinarily important, because we have these large programs. They are large programs. Some of these programs are the largest in the world for children. So something to be proud of, no doubt about it, something to be proud of. But it is a kind of one size fits all, very little scope for nuance, flexibility, decision making. And in fact, people are not trained to do that also. They're trained to follow the implementation the way it is directed from New Delhi all the way down to the entire country, and not shift anything from the given guidelines. So the children who are needing specific attention, there's no way of red flagging, prioritizing. This child needs something more than this child because it's really urgent. That kind of case work does not happen within the system, and it's very important in RBSK. I'm really happy that Rama, specifically in conversations before this, mentioned RBSK to me, because in some sense we're managing some degree of food security and so on. But what we're not managing well, and Odisha is also not an exception in that, is the health care system to take care of illnesses. So most of the mortality is happening from children who are malnourished, just quickly getting sick and dying before any system can really step in. RBSK has, for instance, 6 monthly health checkups, 1 yearly checkups. Now, a child is not going to wait for that 6 months or 1 year to happen. So a child with congenital heart disease, I mean, this I'm speaking from practice and from experience, that we had this one child, Shanawaz will remember, 8 months that child, we struggled to get an echocardiogram and so on. And finally, the child died before we could take action, even though the system, we were all engaged in mobilizing the system. So there is no prioritization happening within the system that can decide this child needs immediate attention, this child needs different attention. And there is I mean, we've been making recommendations on exactly what can be done to do this. I don't think I have time to get into that, maybe some other webinar. Very poor monitoring based on data, so including anthropometric data. See, a child in the severe acute malnutrition status, meaning red child, a child in red, like a SAM child, their two children can be entirely different from each other. One is a child in the severe acute malnutrition category that was going along its line, along its curve in the red zone. Nothing much to worry about there and nothing much you may be able to do also over there, though you should keep trying. But there's another child that may not even be red, maybe in yellow and orange, but has come steeply down from green. The curve has shifted, slanted downwards. That child is very different from this child going along its curve. Now, this kind of understanding, which should have happened by now, all of us are engaged in making it happen, and we have made it happen in protocols on the ground, is not existent in the system at all. So very poor monitoring based on data. This I've already said, poor prioritization, red flagging. We call this red flagging in our program. We have a list of red flags, which every creche worker or every childcare worker is trained, every health worker is trained to recognize. These are red flags. You can't wait around. When this happens, got to take action, refer, so on and so forth. Yeah. Poor case management. No focus on dietary diversity. I mean, I think that this point need not be said in this audience, that one of our largest problems today in the country is not filling stomachs, and especially children's stomachs whose size is as small as their own fist. I mean, that's not the problem. The problem is not a fistful of rice. The problem is the quality of the food. Our minimum acceptable diets is still at 11% or something. It's really pathetic and something that we really need to focus on in all our programs. So these are gaps, it's a gap in the ICDS. It's a gap in the midday meal. It's a gap in the PDS. What are we doing to improve dietary diversity? Is there even scope in the program? Is there flexibility for making local foods kind of more available within the menus and so on? Is there scope? Is there scope and flexibility? And who's going to take those decisions? Do they have the capacity to take those decisions? So this is one slide, but I think that this is really a very important kind of backdrop to any intervention that needs to happen. So local, natural, culturally acceptable, these things are not figuring just now at all. We are putting in more and more processed foods, fortified foods, and so on. We're taking away actually the agency of the local community from the nutrition of their own children. Natural, I say specifically because food safety is something really far from us. Like climate change is something we're just beginning to figure out, climate change and malnutrition, and MSSRF is kind of heading in that direction strongly. But food safety is something that's a critical gap, and I've been trying to work with farmers groups on that. So these are the main gap areas that we have seen across schemes and programs, across child ages, that we try to make sure that our intervention kind of tries to cover this ground. And lastly, and not least at all this is going to depend, if we want all this to happen, it depends on community ownership, voice, people being able to say, this is what we want, this is what we need, this is what we like, this is what we dislike. And these spaces are completely lost, even though we do have arrangements, even in the Act, even in the NFSA Act, we do have arrangements for community-based monitoring. We do have arrangements for social audit, but I think this is the weakest link in our schemes and programs today. And I must say that political will is also not there, not in a state like Odisha, maybe they're very good. But in other states, I don't think that the governance mechanism really wants to hear the truth from the ground, and it's not encouraged. And everybody is becoming hesitant to even use terminologies like social audit for some sad reason. Not us, but I think it's a very sad day when you have to be apologetic about doing a social audit or demanding a social audit because it's public money. So I think this is where we stand. Now, there was a question from the organizers whether a single policy is needed or not. I'm not sure how to answer that question. I do feel that despite nuances and flexibilities being required, that space needs to be created within national programs, because overall, it's not that one child sitting in Bihar, one child sitting in Jharkhand, one child sitting in the Northeast. It's not as though their requirements are going to be vastly different from each other. They're all human children. Everybody needs dietary diversity, so on. So you need to carve out the nuance and the flexibility, but within an overarching, strong kind of domain where there are enough resources, enough policy framework, and so on, enough even legal framework, I would say, to make sure that entitlements can happen. So I am strongly in favor of national, but within that, flexibilities, and those flexibilities will only come from community participation and community ownership. So that is the kind of thing that we need. We need universal, but we need targeting within the universal in some sense. So that is what we are saying. So it's not targeting versus universal. It is targeting within universal. It is prioritization within universal. That's the kind of scheme and policy that we need. And we know how to define those schemes and policies, by the way. Don't have time to get into it too much. Okay. So my interventions, this is the typology of my own interventions that I have physically been involved with as a human, activist or whatever, as a technical person in this area. And there's been a lot of stuff published. You can see that on my profile, and the organizers have been kind enough to put in the chat box, and you can have a look at those papers. There's evidence, there are papers, there's discussions, analysis. Now, broadly, I would say that they fall into these categories, and we try to do these together. Because there's no one solution, when there's no one solution to malnutrition. I think we all know that, multifactorial, complex, but that should not prevent us from taking action. I think that often becomes a way of saying nothing is possible because they're so complex and so multifactorial, is completely wrong. So what we try to do is, you can start with one intervention, but you must layer on other interventions alongside and make it comprehensive and integrated. I'll try to demonstrate that in the coming slides and photographs if I have time. So participatory learning and action on nutrition is fundamental to any other intervention that's happening at a village level or community level on nutrition. Direct interventions, the model that I'll be talking about basically will be the childcare model, with the entry point has been malnutrition, community management of malnutrition. As I said, community-based monitoring, social audit, and lots of work on policies, especially today relating to obesity, relating to food labeling, relating to front of pack labeling, relating to curbing false advertising, and relating to the promotion of junk foods and so on. So this is the kind of policy work that we've been strongly engaged in also. So now coming to the main intervention that I'll probably be spending a fair amount of time on, which is the mainstreaming of creches to reduce malnutrition in Odisha. And so both of the speakers today happen to be Odisha. I think that's not a coincidence. Odisha is a state that has historically done a lot at community level with its SHG program, and nutrition has been one of the main focus of work in Odisha, and it's been a pleasure to be working in Odisha. So the conceptual framework for intervention, I think, again, this group really understands it very well. So I talked about care for prevention, maintenance, and cure, and care that will encompass issues related to health, to food and feeding, to early stimulation, very important, and to safety and protection. And this care is basically provided by women. So it's women's own time, own energy, own health, and own nutrition. That is a big factor in providing this care. I mean, conventionally, this has been the case. It's left to women to provide this care, especially in the first 6 months of life, where she also has to exclusively breastfeed. Now, the creche basically not only takes care of 550 of the 1,000 days, it basically supports this woman to be providing this environment of care for all this to happen. And it also assists the woman herself per se, because she can look after her own health, her own nutrition, her own recreation, and her own livelihoods. So her social economic, I mean, like, we think that every livelihoods program, there should be an attached creche program, and perhaps vice versa. Every creche we've tried these experiments also. And the other person that this helps is the older girl, because we know that sibling care is still very prevalent in our communities, and the older girl is liberated to go to school, which changes her whole life. So this creche program is not just for children, it's the entire community and entire population getting affected by this in the positive sense. So our program, this is what I'm describing, but I'm not going to spend too much time on the program itself. So about 150 community-based creches we started as an NGO. And then slowly, this program has been taken up by various departments in government. I'll come to it. And essentially, we were trying to create continuity of care between the community and the ICDS program, the ASHA, the ANM, NRCs, and so on, and the health system. And then to create a model that can be scaled up. So demonstrating what it costs, for example, what are the human resources required? What is the capacity building required? What food do we give? What protocols do we create for semi-literate or non-literate creche workers to be delivering at the community level successfully? The location is all south of Odisha, deep tribal areas, and very many PVTG areas there also, right? So it's a comprehensive ECCD program. We don't believe that nutrition can stand alone, health can stand alone, and early stimulation will stand alone. No, nothing doing. It has to be everything together. The child is a human being, and all comprehensive entitlements and practices have to be conducted simultaneously. Is something that mobile creches, PHRS, all of us understand and practice. This is just to give you a visual image of this absolutely beautiful creche in the PVTG area, which has been decorated so beautifully by the community themselves. This is the mother coming with her 2 babies to the creche. I'm just going to show you the activities just quickly through photographs. This is the food and feeding, and as you can see that eggs play a very big role. You'll see eggs very prominently displayed everywhere, and they are immediately taken by children. Like there is such delight that children have in eating eggs. Is just something, a joy to witness. I have some video clips, but I don't think I have time to show them. But child just taking an egg in its hand and just like gobbling it up before it gets started on the rice and the dal and the dalma. And there's a big focus on that. So this thali, for instance, would be 1 day's meal. On the right lower corner, if you can see that, this has come from a creche from 1 midday, 1 afternoon meal. All these veggies were there all together. Sometimes they're contributed by community. They will bring handfuls of something, and we just put it all together in a pot food. Hygiene, very important role, hand washing, and of course, it's children coming to the creche. So I'm not talking about mothers hand washing. Somebody asked me that question earlier on the slides. But hand washing, nail cutting, and so on, and the creche workers, their own hygiene also. But these things are talked about in the community so that it flows from the creche to the others in the community also. Early stimulation, very strongly focused on. We've learned a lot from mobile creches. Very difficult to also get started in tribal areas, I must say. One of the challenges to take care of toys, to replace them. Playing like this is not something that's part of the culture of tribal communities. Really, we try to resurrect some songs also, but we really can't find much that people do with very young children. So I think this is a area for sleep and rest. You can see they sleep like this so beautifully in one line, all huddled together under a mosquito net, because mosquitoes are a big problem in Odisha. So sleep and rest. Growth monitoring, very critical to our programs. If it's going to be a technical intervention, and malnutrition can't do it without good growth monitoring. And most of our lives are spent trying to get this right. It's not easy, but it's really worth it. So this is something that we focus on enormously. I mean, I can do whole webinars on our experience and learnings from growth monitoring. Now, the governance is important, very important, because we are also there. We are also governing in some sense, and we are making inputs, and we're insisting on certain things and certain norms. But the community plays a major role. From the decision to open a creche in the village, the community has to say, yes, we want this. Otherwise, we're not going there. Selection of the site, selection of the creche workers, menu planning, deciding timings based on the agricultural cycle. Timings are going to change. So it's not going to be the 9 to 5 or 10 to 6 timing every day of the year. It depends on them what they want. Just as it would for any other middle class mother or parent taking their child to a creche. It's their decision how long they want to leave the child. Do they want to take it away? So you can't enforce. Government is very used to enforcing. No, you have to prove that the child is there for whole 8 hours. We don't function like that. It's a community resource. And if they feel that there's a benefit to it, they will take it. Why would they not? It's a trusting environment. We are not running a program and laying down rules and regulations for the community to follow. And we find that it does pretty well. Maintenance of the creche, beautification of the creche, providing for vegetables and extras like slippers and so on. But very importantly, also to resolve conflicts. If there's a caste problem happening because 2 creche workers are maybe of different caste, because we insist that we're not going to discriminate, sometimes on the basis of religion, sometimes some child fights with another child. You know how it is with schools and daycare programs. So resolving conflicts, discussing the nutritional status of creche children. These are the children currently in the red. What can we do about it? How can we help each other? So on and so forth. And very importantly, monitoring accounts and managing funds. So that's not left to the organization, not left to government to make sure that koi chori nahi ho raha hai, nobody is stealing. Let the community take care of it. So accounts are presented to the creche committee. Every creche has a creche committee where the mothers are definitely there, but it's also frontline workers. It's also panchayat leaders and so on, SHG leaders. So it's a kind of a comprehensive committee. This is a creche committee meeting, just to give you a glimpse of. Yeah. You can see, like, none of us are there. I mean, they're all discussing things, and the creche workers lead it generally. Now, what I said about earlier, that integration with participatory learning and action with nutrition sensitive agriculture and livelihoods action. Livelihoods, we've done very little. I wish we could do more. We haven't managed to kind of raise funds for this, but very exciting that we tried something. We tried an experiment, which I'll refer to briefly, but we try to do this. So PLA is a must. And you can see from this list of, we've done in Odisha, we've done 10 modules only, but in other states, like 15 states, we did with Pradhan, with their SHG groups, 1 lakh women. There we did an 18-month cycle, a list of 18, there's a much greater focus on health there, but and on reproductive health also. But here it is basically about infant and young child feeding, child health, and so on. So these are the and we use a lot of audiovisual material, pictorial material, because most of our community is still not literate, especially the women. So you can see that these are these large picture cards, there's flow charts, there's a little game happening somewhere. And you can see again, none of us are present. These are creche workers. Sometimes the Asha will also come in and assist, as you can see, and red sari with it. So it's just happening at the village level. It needs a lot of hand holding and a lot of capacity building. There's no doubt about that. The kitchen gardens we are particularly proud of, and how beautiful they are. So you know more about all this than I do, but every creche we try to make sure, and in the community also in general. Now this is this Lano you're seeing on the side. No, this was linking livelihoods action with nutrition outcomes, where we try to do a little bit extra on vegetable growing with the horticulture department and the agriculture department. This is, you can see some shots of that. And we try to do an extra on backyard poultry. It was quite an experiment. The first round of poultry all died. They all got some disease and they all died and so on. But anyway, because the community is quite used to backyard poultry, we try to add this. We also try to add mushroom farming that did very well in the market also, but also for their own eating. So these are the things that we tried. Always linkage with ICDS and health, always. The anthropometry we try to do with them, the capacity building that happens for the creche worker, we try to involve them. The referral always happens. I mean, all government protocols are followed. If there's a child with severe acute malnutrition in our program, they will be referred. The Asha will be told, the Anganwadi worker will be told. They will be advised to go to the NRC. At the same time, we have our own system of prioritization. Which children are we going to very actively engage with, even if it sometimes means we do all the work because we want to save a life. Sometimes it comes to that. So, but the system, we work very closely with the system. They appreciate it. At all the sector level meetings, for example, that happen in the block and district, creche, the creche system people are also called in. The program managers are called in. They do a report of the malnourished children. We send a list of malnourished children to the DM every single month. We are in close contact with the CMO, the RBSK, through WhatsApp groups and so on. So the system is everywhere. The system is there. The system feels at the ground level. The system feels this is our creches. I mean, trust me, I've seen it being said in government meetings. Now the recognition, this is very important to us, that it's basically the tribal department has taken up this under their PVTG Nutrition Improvement Program, OPNIP. And so 25 of the older creches were taken up and 36 new creches and many more in the plan. And they have also now talking about engaging us as the PMU for continuing to run this a little bit longer. Simultaneously in Keonjhar through DMF funds. So different funds have been, kind of mobilized to run creches. And Odisha, look at the numbers. I mean, I don't think there's any other state. And it's all being done in the name of nutrition. So it's just fantastic. 731 new creches in Keonjhar from DMF, 2,418 plan from Omba DC, not moved very fast. And now Azim Premji is gone. Azim Premji has really been funding all this, really. Has now decided to run 8,000 creches through NGOs, though, in Odisha, Jharkhand, and Chhattisgarh. And the department, we were so proud, got a Scotch Gold Award last year for the OPNIP program, which included the creches. And the department was very proud. We were very proud. Evidence, it's very clear. So this is 308, children with severe acute malnutrition. And you can see that other than 11% that stayed in the red category, all of them improved grades. And after all that improved grades, a vast majority, more than 1/3, actually went to all the way to normal from red. So, and this is all statistically significant, all been published. Don't have time to really discuss data too much, but I do want to show you, it's very significant that amongst all types of malnutrition, there's a rightward shift of the entire population. Now, those of us who know public health will understand how critical this is, or even a small shift to the right makes such a big difference to the world. So, and you can see these rightward shifts, they are really quite important for us. And we've been demonstrating this for 10 years across not just this program in Odisha, across the earlier program Action Against Malnutrition and in other states, across many different phases of this program itself. It's the same pie chart we see. It's the same graphs that we see again and again and again. Shanawaz can vouch for it. Seasonality plays a big role, but overall you can see that it's a downward trend. But seasonality, look at the ups and downs, and that one spike you see is COVID. You see that one spike in April, May, or whichever year that was, I hope you can see that very sharp spike in between. That was COVID. But look how quickly it also settled down in the creche areas. Now, the challenges are very typical. I think the lack of interdepartmental coordination between the departments, especially health and WCD, can be a problem, though it's not so much of a problem in Odisha, I feel. And it's not so much a problem in the ground, because the AAAs, the frontline workers, they coordinate with each other, not a problem. I think it's more a problem in at the higher levels, the higher we go, and especially at national level, it is really quite a strange phenomenon. The lack of dedicated funds, every now and then a new program starts as an innovation and then clamps down or shuts down or disappears because the political dispensation changes. The funds that were scrabbled from here and there because they were not dedicated, they disappear. So this is a huge challenge for all of us. We just start from scratch every now and then. I mean, it's been years and years for all of us in advocacy. This is the farthest we've got after, I would say, 50 years from mobile creches, 30 years from us. At least it's the farthest that we have got this time around in the last, say, 2 or 3 years. Inaccessible terrains, very hard for people to reach, very hard for supplies to reach. Sparse populations, this is very important also. You need a critical number of children to open a creche for. So that's a limitation of this intervention, that you can't run it for 1 or 2 children in a scattered hamlet of 20 households, which still exist. So we need a different kind of model for that, which is something that's a challenge for us. And we're also thinking about how we can do that better. Lack of space and lack of buildings in these areas, in tribal areas, there is just, the land is all topsy-turvy, and there's no government land as such. Government buildings are in very bad shape. So space, safe space is still continues to be a very problematic area for us. Whether we recognize it or not, but caste still plays a role in tribal areas also. And finding literate, semi-literate women as caregivers, defunct SHGs, if you want to run it through the SHG model, which is possible. We think it's entirely possible to do that. And you need a continuous and strong handholding. So there's no case of building a creche and just handing it over to the community and walking off forever into the sunset, which is, and government doesn't like to fund for capacity building, hand-holding, monitoring, supervision, but this is critical, and this human resource will have to be invested in. Okay. That is it from me, and I still have 2 minutes to spare. So thank you very much. I look forward to questions.
Yes, thank you so much, Dr. Vandana, for the nice and so beautiful experiences to share with us. And the presentation was also very clear, and our participants and audiences can very much link with their field experiences with your presentation. So I would just like to summarize the whole presentation. I definitely will accept that there are many schemes and programs which are there to address this malnutrition issue. But yes, there are. Am I clearly audible, or there is any echo?
There's an echo. There's an echo.
Okay. I think somewhere in. Now is it clear? I think somewhere in. Now is it clear?
It's okay.
It's okay. It's okay. It's okay. Hello?
Yes, it's muted.
Okay. So what I understand is that this has been totally given to health and WCD department, and the issue like malnutrition needs special attention, particularly the people living in the tribal areas. And the word care, very well, Dr. Vandana said that a special focus in the form of care, in the form of services is missing. That we are simply implementing the programs in the name of program implementation and the directions given in the guidelines. So yes, special attention is required. And monitoring is also missing, because one of our um, participant also asked one question whether the Potion tracker has also made, due to Potion tracker, whether we have stopped monitoring through growth monitoring chart. So there are some of the areas that we still miss. And definitely the crutch system, which you very well presented here, highlights that how the 380 SAM children, severely acute malnutrition, the children suffering from, have been reduced very well to the green normal level. And special attention is required according to the need, means it is not based on the equality, it is based on the equity approach. So according to the need, the crèche facilities, the children are getting all kinds of supports. So yes, and your type of intervention was also quite very deep. That is, the intervention was through participatory and learning action, which is involving whole community, and particularly the mother, women, pregnant women, and also the adolescent girls. Somewhere I have seen that. So also we have you are trying, always trying to develop models so that it can be very well scaled up. And also you have given that monitoring to the community so that it will be more sustainable in the long run. And also you also advocated for the policy level actions and campaigns so that it could bring out attention from different sections of our society. Now the context of the whole program is that the children under 3 are highly mostly vulnerable, so they are also lack the poor feeding practices. And there are program challenges. Yes, I would also like to share that these programs basically focus on the myths around food, and the social practices around food, particularly for the food intake practices of the children. And also, from my experience, I would say the food practices and myths of food habits during pregnancy and lactation period also affects their children. So these are some of the programmatic observations, and that is I have observed from your slide. And thank you so much, Dr. Vandana. Now the floor is open for question and answer session. So yes, as I said, the first question was on how the, if the Potion tracker has eliminated, whether the use of Potion tracker has eliminated use of growth chart. Dr. Vandana, do you still use growth charts? How could the mothers know about their children's status?
Yeah, thank you so much for this very important question. There's a lot to say about Portion Tracker, and there's a lot to say about growth charts. I think growth charts are absolutely critical for working on malnutrition, and they serve as an excellent mobilizing tool and communicating tool in the community. We've even made, enormous flexes for growth charts, and every child is made to stand in their status, and like a saap sidi ka khel kind of thing can happen. And so everybody understands growth charts. The creche workers understand it, the mothers understand it, the fathers are interested in it, they understand it, communities understand it. And unless you can see the trajectory, like I said, the slope in a growth chart, you can't actually evaluate a child. So as a pediatrician and as a practitioner, I think growth charts are critical. The Portion tracker should not insist that growth charts not be used. And in fact, it doesn't. The Portion tracker also has some elements that are helpful to the Anganwadi worker. They've come recently as a result of recommendations made by us. In being able to track a child's, track the child's slope of growth. But the Anganwadi workers have not been trained to do that. They have been trained on the growth chart, what a slope is, an upward line, a static line, and a downward line. They were trained this for the growth chart, but they have not been trained how to identify all this now in the Portion tracker. It's going to take some time, but I think a growth chart for every individual child is very important and should not be disbanded, This would be my strongest recommendation. It's very important. On the portion tracker, one strong recommendation, I'm saying it because I really want advocacy for this. Please requesting everybody, all authorities to fight against doing monthly heights. Yeah, again, I've written this up technically, the arguments against doing monthly heights. And yet the Anganwadi whole system is beleaguered to doing monthly heights, which actually they're not doing it. They can only falsify heights. They can't actually conduct monthly heights for every child. It's an impossibility, practically not possible, not feasible. We are not even doing weights, leave alone heights. And there's a huge amount of false data coming into the system because of this insistence of doing monthly heights and filling the portion tracker and so on. I think system needs to evaluate this properly. Don't just take my word for it, but honestly look at how helpful this is to every individual child's tracking and monitoring. So thank you for that question.
So the next question is, how does the government CMEM program operate?
So it operates differently in different places, but mostly it comprises of providing some extra food in the form of some enhanced, take-home ration kind of thing, or sometimes a ready-to-eat kind of thing. There have been different experiments. In Maharashtra, they use RUTF, plumpy nut variety of type of RUTF. In Odisha, they've been using something that perhaps the next speaker will talk about, which is basically SHGs are making something that is slightly more calorie dense and has more micronutrients and so on. So this is a way in which, so some extra food, sometimes it is just double ration, and some extra monitoring is supposed to happen, meaning more frequent weighing and measuring of the child. That is essentially you see, malnutrition happens as a result of a resource deficit. So you've got to add resources to make malnutrition better. It can't just be by conversation. I don't believe that behavior change, it can make a small difference, behavior change communication, about 5% difference. But otherwise, in these contexts, I'm saying very poor, very deprived, very marginalized communities, you have to add resources. So the resources being added currently by the CMAM programs that are envisaged by the government is some extra food and some extra growth monitoring. I'm not sure, referral is also there now in the new guidelines that have come out. So there is a hint of red flagging in the new guidelines, thankfully, after much advocacy and writing up from our side. So these are the things that the government would do. The care component doesn't get taken. So it's not just lack of knowledge and lack of information and culture. As I'm saying again, it is also women being very busy. Look at time use studies for women in tribal areas. They're working 16 to 18 hours a day sometimes. And we make a recommendation, make 5 hot cooked meals available to your child at the age of say 9 months or 10 months. How is she going to do that? No? She's too busy. So that's what the CMAM program is. It's a good start, but I think that we can certainly, supervised feeding is missing. That's our basic thing. Supervised feeding needs to happen. That's missing currently in the CMAM program.
Okay, thank you. And another question is here, how can we address the nutritional deficiencies in tribal areas where vegetable intake is less than 15% of the recommended dietary allowance, and both midday meals and take-home rations predominantly consist of pulses and cereals, leaving essential nutrients, micronutrients, lacking in the diets of children and mothers?
I think I spoke a lot about that. I mean, like, it's not even pulses, by the way. In our experience, it's just rice, and very little pulse consumptions also happening. But it is by enhancing the meals that we are feeding directly. You saw how much vegetables was used, the kitchen gardens, the PLA. I think that we've been advocating that in the PDS itself, we can definitely add oils and pulses at least, if not, and eggs everywhere, eggs in midday meals. I mean, Odisha is giving eggs, huge number of eggs to the children through the ICDS system. It's the only state. No, not the only state. Tamil Nadu also gives. Some other states give in the south also. But in midday meals is creeping up a little bit. Some states like Jharkhand started to give midday meals, but not ICDS. So eggs and why stand against non-veg foods? I mean, like in our creches, it's for the creche committee to decide if they want to save some money from somewhere and or contribute money and serve chicken. We have no problem with it. So there should be no kind of discouragement to non-vegetarian sources also of food where it's culturally acceptable, desirable even. So eggs and vegetables and fruits, local. I think I've shown slides and said how this can be made to happen. And it can be made to happen. Yeah. But there's also stuff to do in agriculture. I mean, I'm not an agriculture, so I'm not going there. But there's also a lot to be done in agriculture, and we've been trying to work with the communities of farmers to make sure that don't just grow cash crops, for example. You must save some amount of land for your own use and for growing fruits and vegetables. So that kind of work, how the horticulture, I did mention, how the agriculture and horticulture departments can help by keeping nutrition as a lens, not just the market for selling food produce. I think this is very important. And this is something that I tried to also say. Yeah.
So, ma'am, one last question from me. That what do you say that if we invest on the preconception stage women, the women who are in the newlywed women and the pregnant women and lactating mothers, will that also affect the malnutrition level of the children?
Excellent question, and 100%, of course. I mean, like, I didn't have time to get into it, but one of our greatest success stories in the PLA work has been to stop early marriages. I mean, the women have just taken up that campaign and just run with it. Stopping early marriages very passionate about it. No, no, please don't get your daughter married. And so early marriages, early pregnancies, low birth weight, all this is very, very important. The whole life cycle, we try to use the whole life cycle approach, but since the topic given to me was specifically on the young child, I stuck to that. But otherwise, we try to work with adolescents, we try to work with pregnant health. And in Odisha, the OPNIP program, in fact, has started spot feeding for pregnant and lactating women also, co-terminus with the creche, as well as feeding child feeding centers, or for children who are not able to come to Anganwadis because the distance is too large between the I mean, people who are familiar with Odisha know that there's maybe one Anganwadi in a larger village, and then there are many of these tagged villages. So the population is shown up in the Anganwadi register, but these tagged villages can be 4 to 5 kilometers away through jungle, through hill, and so those children are not able to come on a daily basis for hot cooked meals. So we need a comprehensive approach that tackles, and I would say it's not just the life cycle for this intergenerational thing. It's also elderly people, people who are sick. What about their nutrition? Children with disability. There's a huge amount of work to be done for every single. I mean, like, our nutritional state in India is really pathetic, and practically every person needs some intervention. Sometimes on the obesity side, and sometimes on the side of being vulnerable to undernutrition or to a lack of dietary diversity.
Thank you so much for this brilliant question answer session. So now I would request our second speaker, Ms. Annapurna Kundu, to proceed. So Nitya, shall we share the screen?
Good afternoon, all. Ma'am, I'm speaking Hindi.
Okay, ma'am. Okay, it's okay.
Young child malnutrition among tribal children. ये ट्राइबल बच्चों का जो मालन्यूट्रिशन रहता है उसी के ऊपर हम लोग डिस्कस करेंगे। और ये तो पहले से ही बहुत रहता है और रहेगा भी, और इसके ऊपर हम लोग बहुत सारे काम करते हैं, जैसे कि सप्लीमेंटरी न्यूट्रिशन फूड दे रहे हैं थ्रू आंगनवाड़ी वर्कर के थ्रू दे रहे हैं। उसके बाद इम्यूनाइजेशन कर रहे हैं, जो एनएम और एनएम के साइड से इम्यूनाइजेशन हो रहा है, हेल्थ चेकअप हो रहा है बच्चों के। हम लोग ये जो चाइल्ड 6 ईयर टू प्रेग्नेंट चाइल्ड और प्रेग्नेंट और लैक्टेटिंग मदर का हेल्थ चेकअप हो रहा है। रेफरल सर्विस, जो बच्चे ज्यादा रहते हैं, जो ज्यादा रहते हैं, जो वो सीमाम प्रोग्राम ये सब में रहते हैं, जहाँ न्यूट्रिशन कम रहता है, उसको हम लोग रेफर करते हैं। लैक्टेटिंग मदर और वुमेन को भी, प्रेग्नेंट वुमेन को भी हम लोग रेफर करते हैं। और इसके साथ हम लोग प्री स्कूल 3 ईयर टू 6 ईयर बच्चों का प्री स्कूल होता है। न्यूट्रिशन हेल्थ एजुकेशन, एडोलेसेंस गर्ल्स और वुमेन 15 to 45 ईयर्स को एडोलेसेंस गर्ल को हम न्यूट्रिशन एंड हेल्थ एजुकेशन दे रहे हैं थ्रू विलेज मीटिंग। हम लोग विलेज मीटिंग करते हैं और उसमें से उसी में से हम लोग ये न्यूट्रिशन हेल्थ एजुकेशन दे रहे हैं, थ्रू डेमोस्ट्रेशन भी कर रहे हैं और उनको न्यूट्रिशन कौन कौन हम सब्जी में हम ज्यादा न्यूट्रिशन ले सकते हैं वही के ऊपर हम लोग ज्यादा फोकस करते हैं। और उड़ीसा में ऐसे देखेंगे तो हम लोग का 71 सेंटर आंगनवाड़ी सेंटर सर्विस दे रहे हैं, थ्रू आंगनवाड़ी सेंटर के थ्रू सर्विस दे रहे हैं। हम लोग का ऑब्जेक्टिव है जो 0 to 6 ईयर चिल्ड्रन का न्यूट्रिशन एंड हेल्थ इम्प्रूव के लिए हम लोग उनका स्टेटस थोड़ा ज्यादा करने के लिए 0 to 6 ईयर चिल्ड्रन को हम लोग न्यूट्रिशन एंड हेल्थ एजुकेशन दे रहे हैं। उनका फिजियोलॉजिकल फिजिकल एंड सोशल डेवलपमेंट थ्रू प्री स्कूल के थ्रू हम लोग ये सब कर रहे हैं। उनको स्कूल स्कूल गोइंग चिल्ड्रन को पहले से हम रेडी करते हैं। स्कूल जब उनको 6 ईयर हो जाएगा तब स्कूल जाने के लिए उनको दिक्कत नहीं होगा। फिर मोर्टेलिटी और मोबिडिटी मालन्यूट्रिशन कम कर रहे हैं। बहुत ज्यादा से ज्यादा हम लोग न्यूट्रिशन दे रहे हैं, THR भी दे रहे हैं। अचीवमेंट एक्टिव कोऑर्डिनेशन ऑफ पॉलिसी एंड इम्प्लीमेंटेशन अमंग द वेरियस डिपार्टमेंट टू प्रमोट एंड डेवलपमेंट। हम इसके लिए हम ऑल डिपार्टमेंट के साथ हेल्प से हम ऑल डिपार्टमेंट के कोऑर्डिनेशन से हम ये सब काम कर रहे हैं। उन लोगों का मदर की कैपेबिलिटी, केयर गिवर जो बच्चों को केयर करते हैं उनका नॉर्मल हेल्थ एंड न्यूट्रिशन नीड ऑफ चिल्ड्रन थ्रू प्रॉपर न्यूट्रिशन हेल्थ एजुकेशन, उनको भी हेल्थ एजुकेशन के बारे में हम थ्रू आंगनबाड़ी के थ्रू ये सब दे रहे हैं। और हम लोग का इसके लिए बहुत सारे स्कीम सप्लीमेंट्री न्यूट्रिशन हम लोग दे रहे हैं। 6 month to 6 ईयर चिल्ड्रन को 30 days न्यूट्रिशन दे रहे हैं। प्रेग्नेंट एंड लैक्टेटिंग मदर को भी दे रहे हैं। और इसके बाद हम 0 to 5 ईयर को एटलीस्ट 1 month में एक बार उनको वजन कर रहे हैं और WHO ग्रोथ स्टैंडर्ड के रजिस्टर में उनको प्लॉटिंग कर रहे हैं। लेकिन अभी हम लोग उसको ये पोषण ट्रैकर में उनको प्लॉट कर रहे हैं। पोषण ट्रैकर ग्रोथ स्टैंडर्ड पहले से हम लोग कर रहे थे, प्लॉटिंग कर रहे थे WHO न्यू ग्रोथ स्टैंडर्ड में। उनको वजन करने के बाद केयर टेबर और मदर को भी हम लोग काउंसलिंग करते हैं। जो बच्चा कौन सी स्टेज में है, कौन से कलर में आता है, ऐसे उनको भी हम लोग बताते हैं। आंगनवाड़ी वर्कर जब वो बच्चे को ले आते हैं और उनको हम लोग बताते हैं जो ये उनका कौन सा कलर में वो बच्चा आता है। और ऐसे सब इसी के हिसाब से वो केयर और मदर को भी पता चलता है जो बच्चे इसी कलर में होता है। उनका बच्चा कौन सा माने कलर में आता है, उनका क्वेश्चन नॉर्मल में है या रेड कलर में है, और उनको भी पता चलता है। उसके हिसाब से उनको काउंसलिंग किया जाता है। और हम लोग सप्लीमेंटरी न्यूट्रिशन ऐसे देते हैं। 6 month to 3 ईयर को अंडा, छतुआ और हलवा देते हैं। और वीकली हम लोग 3 अंडा देते हैं और एग, और 12 अंडा वीकली 3 एग उनको देते हैं। और उसमें से कैलोरी और प्रोटीन के हिसाब से हम लोग उनको अंडा खिलाते हैं। और प्रेग्नेंट वुमेन एंड लैक्टेटिंग मदर को हम लोग एग, बादाम लड्डू, लेते हैं, कैलोरी के हिसाब से ये किया गया है। और 12 एग देते हैं, वीकली 3 एग इनको भी देते हैं। और उसके साथ हम छतुआ 4.4110 ग्राम की छतुआ उन लोग देते हैं। उनको महीना में उस छतुआ उन लोग लेते हैं। और उनमें से उन लोग ज्यादा से ज्यादा कैलोरी ले सकते हैं। एडोलिसेंस गार्ल, एडोलिसेंस गार्ल को भी हम लोग अंडा छतुआ देते हैं। और अंडा 16 अंडा महीना में 16 अंडा देते हैं। और छतुआ 3.6 केजी उन लोग को देते हैं। कैलोरी के हिसाब से कैलोरी उन लोग पर डे कैलोरी 815.227 कैलोरी उनको मिलता है। और प्रोटीन 29.295 कैलोरी उस उन लोग उसमें से पा सकते हैं। तो इनमें से इनको कैलोरी भी मिलता है। और इसी हिसाब से हम लोग सब ये आंगनवाड़ी को ट्रेनिंग दिया हुआ है। और माँ और जो लेते हैं हम लोग बेनिफिशियरी को भी हम लोग इसी हिसाब से ट्रेनिंग दिया हुआ है। उन लोग किस तरह से ये सब घर में लेकर उसको यूज करेंगे, उसको भी हम लोग हर मीटिंग में, हर महिला मीटिंग में और VHND में, और VHND जब होता है तभी भी हम लोग उनको ट्रेनिंग देते हैं जे कैसे इसको खाना है और कैसे इसको प्रिजर्व करके रखना है घर में और उसको लेना है। तो इसी हिसाब से हम लोग का अंडरवेट जो होता है, अंडरवेट रेट हम लोग 41% to 25% ज्यादा से ज्यादा फोकस करके शेड्यूल टाइप करते हैं। एवरेज एनुअल रिडक्शन हमको 3.5% होता है। और स्टॉन्टिंग जो होता है, स्टॉन्टिंग में 45% to 35% एवरेज एनुअल रिडक्शन हम लोग का 2.5% होता है। वेस्टिंग रेट 20% to 10% with an average annual reduction 2.5%। रेट ऑफ LBW ज्यादा से ज्यादा एनोकमिक मदर और प्रेग्नेंट मदर में देखा जाता है। LBW बच्चा जो जन्म लेते हैं उनको, उनका भी थोड़ा ज्यादा होता है। और ज्यादा बिलो 18 ईयर मैरिज उनको भी ज्यादा ये LBW बच्चा पैदा होता है। और उनको थोड़ा ज्यादा हम लोग फोकस देते हैं। और ज्यादा से ज्यादा हम लोग कम्युनिटी में मीटिंग करते हैं जो चाइल्ड मैरिज बंद करने के लिए, ज्यादा 18 के अबव मैरिज करने के लिए उनको हम लोग बहुत सारे काउंसलिंग करते हैं। और एवरी सैटरडे को हम लोग सैटरडे सेशन होता है आंगनवाड़ी सेंटर में, जहाँ वहाँ एडोलेसेंस गर्ल प्रेजेंट रहते हैं। और वहाँ एडोलेसेंस गर्ल को हम लोग कहते हैं जो 18 ईयर्स उन लोग भी काउंसलिंग किया जाता है। 18 अबव ही मैरिज करेंगे और ऐसे 18 ईयर बिलो 18 ईयर मैरिज होने से क्या क्या उनको नुकसान है, ये सब हम लोग उनको वहाँ बताते हैं। और उनको इंक्रीज हम जैसे इंस्टीट्यूशनल डिलीवरी होगा उसी हिसाब से उन लोग को हम ज्यादा काउंसलिंग करते हैं। आंगनवाड़ी वर्कर उन लोग को पहले से रेडी करते हैं जो इंस्टीट्यूशनल डिलीवरी के लिए। हम लोग का चैलेंज रहता है जो क्या पेरेंट्स एंड केयर गिवर को हम उनका जो न्यूट्रिशन रिक्वायरमेंट रहता है स्मॉल चिल्ड्रन के लिए, उनको कैसे हम लोग ज्यादा से ज्यादा उनका माइंड सेटअप, उनका ट्रेडिशनल जो है उनको चेंज करना है। उसी हिसाब से वो ट्रेडिशनल जो रहता है उनका फूड टेक का उसी को हम लोग कैसे रिड्यूस कर सकते हो, ज्यादा से ज्यादा न्यूट्रिशन फूड उन लोग ले सकते हैं, उसी के ऊपर हम लोग का ज्यादा रहता है। और उनको जो फूड लेते हैं उनका यहाँ ट्राइबल एरिया में हम लोग देखते हैं, जहाँ हम लोग का जो मेरी एक्सपीरियंस है, यहाँ पर मिलेट ज्यादा कल्टीवेट होता है, तो उन लोग ज्यादा के ज्यादा मिलेट खाते लेते हैं। इसी के हिसाब से थोड़ा उन लोग के हिसाब से थोड़ा कम रहता है उनका न्यूट्रिशन हैबिट, न्यूट्रिशन थोड़ा कम रहता है। न्यूट्रिशन हैबिट को कैसे हम लोग उनको ज्यादा से ज्यादा न्यूट्रिशन फूड टेक करेंगे, उसी के लिए हिसाब से हम लोग छतुआ टीएचआर देते हैं। और वो छतुआ कैसे उन लोग टेक करेंगे, वो छतुआ में क्या क्या रहता है, उन लोग की हम लोग ज्यादा से ज्यादा आंगनवाड़ी वर्कर के जो मीटिंग होता है उनमें हम लोग बताते हैं इसको लेने से क्या फायदा है, और बच्चे को ठीक टाइम में और ठीक हिसाब से देना चाहिए। अर्ली मैरिज तो हम लोग बोलते हैं, जो अर्ली मैरिज में कैसे LBW बेबी होने का चांस ज्यादा होता है, तेनो उनको भी हम लोग अर्ली मैरिज रिड्यूस कैसे होगा, उसको हम लोग एवरी मंथ में जो होता है हम लोग का सैटरडे सेशन, उसमें बताते हैं। और भी हम लोग जो VHND होता है उसी में से वहां पर भी हम लोग बताते हैं। और उन्हीं में से उन लोग ऐसे ही उन लोग वहां से ही सब एनीमिया, प्रेग्नेंट वोमेन और गर्ल्स, एडोलेसेंस गर्ल और प्रेग्नेंट वोमेन में ज्यादा ज्यादा देखा जाता है एनीमिया। और एनीमिया कैसे कंट्रोल होगा, उसे हेल्थ के ये जो हेल्थ में रहता है, जो उन लोग एनीमिया के लिए उन लोग आयरन टेबलेट देते हैं हर सैटरडे में। और उसी भी से हिसाब से उन लोग 6 मंथ टू 5 इयर्स भी हम लोग आयरन फॉलिक एसिड देते हैं। और गर्ल्स लोगों को भी आयरन टेबलेट, प्रेग्नेंट वोमेन भी आयरन टेबलेट, ऐसे हेल्थ के जरिए में उनको दिया जाता है एनीमिया कंट्रोल करने कंट्रोल के लिए। अब ज्यादा ज्यादा उनको हम लोग ऐसे होता है, ये एक चैलेंज रहता है, जो वोमेन लोग वर्किंग लेडी ज्यादा रहते हैं, तो वर्किंग लेडी रहने से क्या होता है, बच्चे लोग को घर में छोड़ कर उन लोग काम करने के चले जाते हैं। इसीलिए उन लोग का फूड हैबिट और उनका जो क्या टेबल रहता है, उसी के हिसाब से थोड़ा बच्चे ज्यादा ज्यादा माल न्यूट्रिशन होते हैं। उसका थोड़ा हम लोग उसी के हिसाब से हम लोग उनको भी हम लोग देते हैं, जो आंगनवाड़ी सेंटर में बच्चे को पढ़ाओ। और वो सब थोड़ा हम लोग के लिए थोड़ा चैलेंज हो जाता है। कंजम्पशन ऑफ लिक्विड ऑफ बोथ मेल्स एंड फीमेल्स इन द विलेज इवन ड्यूरिंग प्रेगनेंसी एंड लैक्टेटिंग फेज। और इनको ये जो उन लोग का हैबिट है, जो उन लोग ड्रिंक करते हैं, लोकल ड्रिंक करते हैं, वो हैबिट उन लोग का थोड़ा, वो भी हम लोग का चैलेंज होता है। उसको कैसे हम लोग थोड़ा उसी से उसको कैसे हम दूर कर सकते हैं, वो भी हम लोग सब मीटिंग के जरिया में हम लोग उनका माइंड सेटअप करते हैं। और ज्यादा से ज्यादा उन लोग ड्रिंक बंद करने के लिए बोलते हैं। जो फैमिली में कैसे प्रॉब्लम होगा, वो हमारे लिए एक चैलेंज रहता है। और हम लोग ऐसे बच्चों के न्यूट्रिशन के लिए हम लोग कन्वर्जेंट सब डिपार्टमेंट के साथ हम कन्वर्जेंट मीटिंग करते हैं। इसके लिए हेल्थ एंड फैमिली वेलफेयर हम लोग उसी के हिसाब से हम लोग इम्यूनाइजेशन, हेल्थ चेकअप, रेफरल शैल बी न्यूट्रिशन, हेल्थ एजुकेशन, और ममता दिवस, जो कि ममता दिवस होता है, और VHND भी होता है। वो VHND में रेफर करते हैं, हेल्थ चेकअप होता है और इम्यूनाइजेशन होता है। ये फैमिली हेल्थ एंड फैमिली वेलफेयर के साथ वाटर सैनिटेशन, हम लोग सपोर्ट वाटर सैनिटेशन, हाउस होल्ड टॉयलेट क्लीनिंग, द विलेज एंड ये सब हम लोग करते हैं। ओडिशा लाइवलीहुड मिशन उसी के हिसाब से हम लोग कम्युनिटी बेस्ड क्रैच ये सब हार्ड टू रीच एरिया 30 डिस्ट्रिक्ट में हो रहा है। हार्ड टू रीच एरिया में हम लोग ऐसे पड़ा पुष्टि किया हुआ है। जो बच्चे आंगनवाड़ी को नहीं आ सकते हैं, तो वो बच्चे को हम लोग वहां पर एक ग्रुप सेटअप कर SHG ग्रुप, सेल्फ हेल्प ग्रुप से के माध्यम से वो को बच्चे को भी न्यूट्रिशन फूड देते हैं। और जो बच्चे आंगनवाड़ी को नहीं आ सकते उसको ये आंगनवाड़ी के जरिए में वो पड़ा पुष्टि भी हम लोग यहाँ पर करते हैं। एग्रीकल्चर डिपार्टमेंट से हम लोग न्यूट्रिशन गार्डन एवरी आंगनवाड़ी सेंटर में क्या हुआ है, और न्यूट्रिशन जो फूड होता है वो बच्चे के लिए हम लोग यूज करते हैं। इसी के हिसाब से और भी हम लोग का अभी न्यू एक योजना हुआ है, मुख्यमंत्री संपूर्ण पुष्टि योजना। उसमें हम लोग गर्भवती, प्रेग्नेंट वुमेन, लैक्टेटिंग वुमेन और एडोलेसेंस गर्ल को हम लोग न्यूट्रिशन फूड देते हैं। उसमें हम लोग मूढ़ी, ये जो पौष्टिक भेल और ये डेट, रोस्टेड चना और बादाम, तिल लड्डू देते हैं 1 महीना के लिए। उन लोग उसको छतुआ के साथ ये भी हम लोग एक्स्ट्रा देते हैं। ऑल प्रेग्नेंट वुमेन, लैक्टेटिंग मदर, एडोलेसेंस गर्ल, SUPW, मॉम एंड सम चिल्ड्रन को भी उसमें से कवर करते हैं। पौष्टिक भेल, तिल, बादाम, लड्डू, डेट्स एंड प्रेग्नेंट वुमेन एंड लैक्टेटिंग वुमेन, पौष्टिक भेल एंड चना टू एडोलेसेंस गर्ल। इसके बाद भी हम लोग प्रीमिक्स पाउच टू SUVW एंड मॉम चिल्ड्रन को भी देते हैं। आंगनवाड़ी वर्कर जहाँ जहाँ SUVW एंड मॉम चिल्ड्रन रहते हैं वहाँ प्रीमिक्स पाउच भी दिया जाता है। और ऑगमेंटेड THR सम चिल्ड्रन अंडर द पूर्ण आहार प्रोग्राम में शाम चिल्ड्रन को दिया जाता है। उसमें ये जो पूर्ण आहार जो शाम ऑगमेंटेड THR दिया जाता है उसको थोड़ा हम लोग उसमें वो छतुआ, वो उसमें ये आटा, गहम रहता है और चीनी, बादाम, उसको रोस्टेड करके उसको छतुआ के बाद उसमें थोड़ा ऑयल और ये मिल्क रहता है। मिल्क को उसको 100 ग्राम, एक बच्चा को 100 ग्राम दिया जाता है और 30 एग दिया जाता है। हर रोज एक अंडा वो बच्चा लेगा और वो 100 ग्राम THR छतुआ जो ऑगमेंटेड THR होता है उसके लिए वो शाम चिल्ड्रन को दिया जाता है। इसमें से उन लोग ज्यादा से ज्यादा थोड़ा प्रोटीन उसमें से रहता है, तो उनको थोड़ा ये इसको 120 दिन तक दिया जाता है। और 120 दिन में हम लोग जहाँ देखे हुए हैं तो इनका थोड़ा इम्प्रूवमेंट ज्यादा होता है। तो उसमें थोड़ा मिल्क और ऑयल रहता है, इसलिए उनका थोड़ा डेवलपमेंट ज्यादा होता है। और पूर्ण आहार प्रोग्राम वाज पायलट इन कोरापुट एंड नवरंगपुर डिस्ट्रिक्ट। Initially, UNICEF and CO provided technical support to the program। और ये पायलट प्रोजेक्ट के हिसाब से कोरापुट और नवरंगपुर डिस्ट्रिक्ट में पहले हुआ था, फिर इसको अदर डिस्ट्रिक्ट में किया हुआ है। कम्युनिटी बेस्ड इवेंट ऑफ चिल्ड्रन सफरिंग फ्रॉम सीवियर एक्यूट malnutrition इन द डिस्ट्रिक्ट। some children identify आंगनबाड़ी, पहले आंगनबाड़ी वर्कर आइडेंटिफाई some children आंगनबाड़ी सेंटर में कितना है पहले आइडेंटिफाई किया करते हैं, और 112 दिन के लिए एक शाम चिल्ड्रन को पूर्ण आहार प्रोग्राम जो है उनको इन्वॉल्व किया जाता है। फिर उनको मेडिसिन ऐसे उनको मेडिसिन भी दिया जाता है, जैसे कि ऐसे कोई विटामिन मेडिसिन और ये कुर्मी मेडिसिन भी दिया जाता है, और ऑगमेंटेड टीएचआर 100 पैकेट फॉर 112 दिन के लिए दिया जाता है। उनको काउंसलिंग किया जाता है मदर को, और मदर के घर में उनको स्पॉट फीडिंग के साथ मदर को ही उनको काउंसलिंग किया जाता है। द चिल्ड्रन इन केस ऑफ एनी कंप्लेंट्स ऑफ रेफर टू द न्यूट्रिशन रिहेबिलिटेशन सेंटर और हायर हेल्थ फैसिलिटी। और कोई उनका जो कॉम्प्लिकेशन होता है तो उसको जो ऑगमेंटेड टीएचआर देने से उनका इम्प्रूवमेंट नहीं होगा, ऐसे कोई बच्चा रहता है तो उनको रेफर करते हैं न्यूट्रिशन रिहेबिलिटेशन सेंटर एनआरसी को रेफर करते हैं उनका, और वहां पर उन लोग का ट्रीटमेंट होता है, उनका जो काउंसलिंग होता है, और उसी के हिसाब से वहाँ रहते हैं। वहाँ इम्प्रूवमेंट के बाद वहाँ उधर से उन लोग आते हैं। उनका इम्प्रूवमेंट वहाँ पर काउंसलिंग करते हैं, और उनका फूड टेक कैसे होगा वहां पर जो काउंसलिंग करते हैं, इसीलिए उनका वहां पर इम्प्रूवमेंट ज्यादा होता है। तो इम्प्रूवमेंट हिसाब से वहाँ उन लोग रहते हैं। न्यूट्रिशन ऑपरेशन प्लान एनओपी के अंडरवेट जो रहता है हम लोग का, ये जो रिडक्शन ऑफ मालन्यूट्रिशन रेट इन कोरापुट में हम लोग का सीवियर अंडरवेट रहता है। ये जो हम लोग का ये ग्राफिक दिया हुआ है, ये जो लो अंडरवेट, लो वेट फॉर एज, स्टॉन्टिंग लो हाइट फॉर एज, मॉडरेट एक्यूरेट मालन्यूट्रिशन माम वेट फॉर हाइट, जेड स्कोर बिटवीन -2 एंड -3 और मुआक मेजरमेंट में हो बिटवीन 11.5 cm से 12.5 cm। ऐसे ही हम लोग का स्टॉन्टिंग थोड़ा माम थोड़ा कम रहता है, स्टॉन्टिंग थोड़ा ऐसे कोरापुट में थोड़ा ज्यादा रहता है। अंडर वेट भी ऐसे थोड़ा है कोई कोई ब्लॉक में, मॉडरेट के हिसाब से भी बहुत कम है। सीवियर अंडरवेट ये ज्यादा नहीं है जो तो पॉपुलेशन के हिसाब से। और हम लोग आंगनबाड़ी सेंटर में इसको थोड़ा ज्यादा ध्यान देते हैं, और जैसे हम लोग इसी हिसाब से ये हम लोग का पोषण ट्रैकर में जो रहता है उसी को हिसाब से हम लोग ऐसे मॉडरेट और ये हिसाब से हम लोग उनको ज्यादा से ज्यादा ध्यान देते हैं। और हम लोग का जो रहता है 6 मंथ to 3 ईयर को हम लोग टीएचआर देते हैं, अंडा, छतुआ, हलवा, और इसको अंडा 12 अंडा देते हैं 3 वीक में, और छतुआ 2.20 ग्राम, और हलवा 1 किलो 350 ग्राम देते हैं। सप्लीमेंट्री न्यूट्रिशन ये टेक होम रेशन उन लोग लेते हैं घर में, और अंडा घर में ही खाते हैं, और इसमें से थोड़ा कैलोरी ज्यादा घर में जहाँ जो भी चीज खाते हैं इसमें से और थोड़ा कैलोरी उनको मिलता है। प्रेग्नेंट वुमेन लैक्टेटिंग मदर को अंडा, बादाम लड्डू, टीएचआर के बाद, छतुआ के बाद ये सब देते हैं। सप्लीमेंट्री न्यूट्रिशन और भी देते हैं 12 एग, वीकली 12 एग को तो वीकली हम लोग 3 करके देते हैं। छतुआ 4.410 किलोग्राम देते हैं। इसमें से वो थोड़ा ज्यादा कैलोरी और प्रोटीन उनको मिलता है। एडोलेसेंस गर्ल को एक छतुआ एक 16 और छतुआ 3.6 किलोग्राम देते हैं। और उन लोग कैसे उसको काउंसलिंग करते हैं, उसको कैसे खाना है, और इसी हिसाब से उन लोग उसको खाते हैं। और हम लोग को हर VHND में किशोरी बालिका का, एडोलेसेंस गर्ल का हम लोग वेट मेजरमेंट भी लेते हैं, उनका हाइट लेते हैं। उसी हिसाब से एनीमिया, ये जो टेस्ट किया जाता है, हीमोग्लोबिन टेस्ट होता है, और उसी हिसाब से जो हीमोग्लोबिन जिसका कम रहता है उसको हम लोग आयरन टेबलेट, हेल्थ की तरफ से आयरन टेबलेट देते हैं। और वो उनका हर महीने में थोड़ा चेक करते हैं, और हेल्थ चेकअप होता है। बच्चों को भी हर महीने में हेल्थ चेकअप होता है। और इसी के हिसाब से ऐसे प्रोग्राम से हम लोग
Yes,
माल
ma'am.
न्यूट्रिशन, यंग चिल्ड्रन माल न्यूट्रिशन एमंग द ट्राइबल एरिया को कैसे हम लोग रिड्यूस कर सकते हैं, इसी के ऊपर से हम लोग काम कर रहे हैं। थैंक यू
Okay.
मैम।
Yes. Thank you so much, ma'am. This is a very good presentation. We have highlighted very important points that what are the food intakes, food calorie intakes, and also what are the food items specifically given to these tribal children and also the pregnant and lactating women. And you have also highlighted the different schemes and programs in very detail, that what is the frequency and what is actually the objective of the state government behind all these schemes and programs. Now, I would like to invite some of the questions from the audience. That is one question I can see here. Ma'am, can you please just say that how do you involve the community in the CMAM program? हम लोग CMAM प्रोग्राम में
हाँ, कैसे कम्युनिटी को इन्वॉल्व करते हैं, तो
जी जी
ऐसे कम्युनिटी को हम लोग पहले तो बताते हैं, उनका गाइडलाइन सब उनको बताते हैं, उनको बच्चे कौन कौन स्टेज में है। सीमाम प्रो शाम में है, बच्चे आप लोग का बच्चा, ये बच्चा शाम में है, तो इनको थोड़ा न्यूट्रिशन ज्यादा देना है। और कम्युनिटी के उसको मदर और कैट टेकर और अदर कम्युनिटी को भी हम लोग इन्वॉल्व करते हैं। और जो सरपंच वार्ड मेंबर रहते हैं उनको भी, SHG ग्रुप, उनको भी सब बुला के हम लोग मीटिंग के जरिए उनको बताते हैं कि ये बच्चे थोड़ा उनको ज्यादा ध्यान देना चाहिए। इन लोग ऐसे एक प्रोग्राम है जहाँ की हम लोग इस बच्चे को हम लोग ज्यादा ध्यान देने के लिए ये बच्चे को हमको हर विलेज में जो जो भी है उन लोग को बताते हैं कि ये बच्चा थोड़ा ज्यादा ध्यान देना चाहिए। उनको फैमिली और अदर लोगों को भी बताते हैं इन बच्चों जो थोड़ा वीक है और इनको बच्चों को ज्यादा ध्यान देना चाहिए, इनको एक ये प्रोग्राम में शामिल करना चाहिए। और इस प्रोग्राम में कैसे इन लोग कैसे ज्यादा थोड़ा हम लोग विटामिन दे रहे हैं, उनको जो THR दे रहे हैं उसमें क्या क्या है और इसको कैसे लेना है, उनको सब बताते हैं। तो कोई जो अच्छा बच्चा रहता है उनके साथ हम लोग कंपेयर करके भी बताते हैं, तो कोई ये बच्चा कैसे एक्टिव है, ऐसे ठीक है, ऐसे ही आपका बच्चा भी ऐसे ही होना चाहिए। ऐसे कम्युनिटी को हम लोग इन्वॉल्व करते हैं मीटिंग के जरिए में।
ओके। अगर जैसे कि हमारी पहले स्पीकर डॉक्टर वंदना ने बोले कि हमारे चिल्ड्रन जितने भी शाम पता लगता है, जो भी बच्चे शाम में आते हैं सीवियर एक्यूट माल न्यूट्रिशन जिनको है, अभी क्रेच फैसिलिटी से उन लोगों में काफ़ी इम्प्रूवमेंट होता है। आपका इस विषय पर क्या कहना है? क्या ओनली गवर्नमेंट स्कीम्स एंड प्रोग्राम्स रिगार्डिंग फूड और आंगनवाड़ी सर्विसेज आर, इफ दे विल बी मोर फोकस, अगर वो क्रेच फैसिलिटी पे ज़्यादा फोकस देंगे, ज़्यादा ध्यान देंगे, तो क्या ये गंभीर कुपोषित बच्चों को सामान्य स्तर पर लाना इजी होगा?
मैडम देखिए, क्रेच सेंटर हम लोग करते हैं तो यहाँ पर क्या होता है, ऐसे ट्रैवल एरिया में कोई कोई बच्चे को छोड़ के घर में चले जाते हैं। तो हम लोग क्रेच सेंटर तो इन लोग को क्या विलेजर ज्यादा से ज्यादा यहाँ एक विलेज में 2 4 की 5 बच्चे होते हैं। तो ऐसे में तो 2 4 बच्चे को हम लोग क्रेच सेंटर एक नहीं कर सकते हैं। तो उनको हम लोग ज्यादा से ज्यादा कोई बच्चा यदि ऐसे उनको ज्यादा बीमारी या कुछ ऐसे पहले से ही कुछ प्रॉब्लम है तो उसको हम लोग एनआरसी को देते हैं, एनआरसी सेंटर को भेजने लेने के लिए बोलते हैं। और नहीं तो ऐसे क्रेच सेंटर में हम लोग ऐसे तो हर गांव में तो क्रेच सेंटर नहीं बना सकते। क्रेच सेंटर बनाएंगे तो कुछ गांव को मिलाकर बनाएंगे, तो उस गांव में वो बच्चे को छोड़ेंगे कैसे? क्रेच सेंटर में छोड़ेंगे ऐसे? हर जगह में क्रेच सेंटर होना मुश्किल है। और हम लोग को करना है कि पब्लिक का माइंड सेटअप करना है। और घर में जो माँ बाप और उनका वो जो फैमिली बच्चों का केयरटेकर होता है, फैमिली मेंबर को हम लोग का माइंड सेटअप चेंज करना है। जो बच्चों को कैसे उन लोग केयर करेंगे, बच्चों का स्टिमुलेशन कैसे बढ़ाएंगे, उनका जो फूड टेक है उसको कैसा चेंज करेंगे, जो गवर्नमेंट में से जो देते हैं जो फूड उसको कैसे लेंगे, ऐसे फूड हैबिट को चेंज करेंगे। इसके लिए थोड़ा टाइम टेकिंग है। और ऐसे तो जल्दी ये सब हो जाएगा कि रातों रात में ऐसा संभव नहीं है मैडम। इसके लिए
ओके।
टाइम टेकिंग।
नहीं, आपको क्या लगता है कि अगर हमारे पास इतने सारे प्रोग्राम्स है तो ये समस्या आदिवासी बच्चों में क्यों ज्यादा है?
आदिवासी बच्चों में ज्यादा है क्योंकि आदिवासी लोग उनको ऐसे तो उनको फाइनेंशियल कंडीशन भी थोड़ा कम रहता है, लेबर क्लास ज्यादा रहते हैं। और उनको जो है फूड ऐसे फूड हैबिट थोड़ा कम रहता है। जो उनका ट्रेडिशनल फूड रहता है उसी को भी उन लोग को पता नहीं रहता है। जो कौन सा फूड में ज्यादा बच्चों के लिए कौन टाइम, मैंने टाइम कैसे कैसे टाइम में उनको फूड देना है, बच्चों को कैसे उनको क्या करना है, ये सब थोड़ा उनको मालूम नहीं रहता है। उन लोग बच्चे को जैसे तैसे ही बढ़ जाएंगे। और पूरा सिस्टमेटिक उनको ये सब पता नहीं रहता है। उनको थोड़ा नॉलेज कम है, एजुकेशनल नॉलेज। और ऐसे बच्चों को वो कैसे इन टाइम में कैसे उनको कौन सा फूड देना है और कैसे उनको हाइजीनिक रखना है, ये सब थोड़ा पता कम रहता है। इसीलिए उनमें से थोड़ा ऐसे माल न्यूट्रिशन ज्यादा दिखाई देता है। ऐसे नहीं कि जिस घर में बहुत सारे एजुकेटेड फैमिली भी माल न्यूट्रिशन दिखाई देता है। और ऐसे किंतु ज्यादा से ज्यादा देखेंगे तो ट्राइबल एरिया में थोड़ा थोड़ा ज्यादा दिखाई देता है। लेकिन अभी धीरे धीरे वो सब कम हो रहा है। पहले से जो हम लोग देखे थे अभी धीरे धीरे कम हो रहा है। लोग
ओके।
लोग सबको
सो लास्ट क्वेश्चन मैम, आप क्या बोलना चाहेंगे कि ये जो आज का विषय जो है माल न्यूट्रिशन एमंग ट्राइबल चिल्ड्रन, इसके लिए आपका सजेशन क्या रहेगा? किस प्रकार से हमें काम करने से हमें ये सारे चीज़ों पे ज़्यादा से ज़्यादा बदलाव ला पाएंगे?
ये मेरे हिसाब से, मेरे एक्सपीरियंस से मैं बोल रही हूँ। जो ये जो अर्ली मैरिज नहीं होना चाहिए, अर्ली मैरिज को हम लोग पूरा पूरी बंद करना चाहिए। और ये लोग हम लोग ट्राइबल एरिया में ज्यादा देखते हैं। ये जो 17 ईयर 16 ईयर गर्ल्स मैरिज हो जाते हैं। वैसे ऐसे तो मैरिज को गांव में ऐसे मैरिज नहीं होते। उन लोग कोई लड़का के साथ चले जाते हैं तो ऐसे प्रेग्नेंट होके आते हैं। तो कोई लो बात बेबी होता है, उसमें से ज्यादा दिखाई देता है माल न्यूट्रिशन। उसको थोड़ा पूरा कंट्रोल करना चाहिए, पूरा माने हल पूरा गांव से और हर एडोलेसेंस गर्ल के अंदर उनको बताना है जो 18 इयर्स के बाद माने 20 इयर्स की 22 इयर्स तो 25 इयर्स, ऐसे उनको एजुकेशन थोड़ा ज्यादा देना चाहिए। माल न्यूट्रिशन और एजुकेशन का डेवलप होने से माल न्यूट्रिशन ऑटोमेटिक कम हो जाएगा। एजुकेशन होने से थोड़ा उसका मदर का भी माइंड सेटअप हो जाएगा, वो बच्चे को कैसे केयर करेंगे, कैसे रखेंगे, हाइजीनिक, ये सब पता चल जाएगा। एजुकेशन इज मेन फोकस रहना चाहिए।
ओके, सो क्या मैं ये बोलूँ, दोनों स्पीकर जो आज हमसे बातचीत हुआ और जो भी क्वेश्चन आंसर सेशंस भी हुए, तो उसमें से मैं कुछ समराइज मैंने किया है, जो कि दोनों स्पीकर्स डिफेंड करते हैं कि कन्वर्जेंस एमंग डिफरेंट डिपार्टमेंट्स आर रिक्वायर्ड, नॉट ओनली एट द विलेज लेवल बट ऑल्सो एट द स्टेट एंड नेशनल लेवल, and both defended for a national policy for all forms of malnutrition, not specific to tribal children. And we have to engage the community institutions, and we have to, so that the community gives better impact then through silo frontline workers. Frontline workers matlab आशा आंगनवाड़ी वर्कर एंड आशा आंगनवाड़ी वर्कर एंड हमारी एएनएम. And not only, it should not be a very departmental kind of responsibility, rather if you would give to the community institutions, then it gives us better result. And also we have to work more on the behavior change and myths around food. जो that Dr. Miss Kundu just now said that yes, there are myths around food, and behavior change towards these practices we have to work on these areas. Besides that, we have to focus on reducing early marriage, early pregnancy, and also means I would say too early, too many, and too frequent pregnancies, where a role of gender transformation is also required. Whatever I understood from both of you. And crèche is obviously a very welcome step to address girl child enrollment to schools, and also for the children. From my own experience, I've seen that the girl child who are enrolled in the preschool in the Anganwadi centers, they are not regularly coming to the center because they have to go with their parents. So when they are going to field to do some agricultural activities, because the Anganwadi Didi herself said what we will do whole day, because our Anganwadi center closes at 12. So what we will do with the child? So these are some of the very core areas that we have to work on, that so that the girl child enrollment for the school going children and the preschool children can continue all the nutrition related services. These are some of the basic summaries. So I hope I made some points what the speakers wanted to say. And yes, Dr. Vandana also written that women female literacy is also plays an important role, and obviously working more on maternal nutrition and nutrition services, health and nutrition services during the pre-conception stage, that is at the adolescent stage, also very important, so that prevention, we can work as prevention is better than cure. We shouldn't focus on the result of the malnutrition. We can also work on the prevention side, so that malnutrition cannot happen. Taking this forward, I would like if some of the audience like to share some of their experiences in a positive note, that whether this malnutrition can be reduced or not among the tribal children. Anyone like to share? Please feel free to share in the chat box if anyone of the right to share some of their experiences. Thank you. We will wait for 1 minute. If I think Bipin Das joined from Kerala, if he has to say something about the tribal population belonging to Wayanad, Kerala, then he can say. And unfortunately, we try to get in some of the community champions, means community level cadres who have already worked on all these areas in Chhattisgarh and Odisha, but they were unable to join this meeting. There is some technical issue, I think. So, anyone else like to say? Thank you, Jasaswini. You were very, yes, agree. Agree. So if you would like to say something, then we will unmute yourself. Just raise your right that you want to say. Otherwise, we are almost done. If Dr. Ashok, you want to give vote of thanks.
Thank you, ma'am, for giving an opportunity to share my views. That I had all like more than 12 years of my experience in tribal area. This is very unfortunate that we are concentrate on food and food only, and we concentrate on the what we said. Only we are focusing only the malnutrition means protein, energy, malnutrition thing. But in ground level, if we see the identification and screening of child malnutrition is very less. What I felt, because sometimes the Anganwadi worker knows that child is needed that perfect treatment and follow up. We carry the child to the NRC, but the parent is the mother is willing to take the child to the NRC, but father is not willing to take the child to NRC. Okay. And third thing is screening and management of sickle cell anemia. Recently, like in my previous job, I was with PHR and also knows that program. And I've seen that many children are suffering from sickle cell anemia, and parents are not aware that the child is suffering from that. And third and more important thing is reducing weight is very easy. Like within one diarrhea or one loose motion happened or one fever happened, the child will reduce the weight very quickly. But the same weight the child will not cover in the next 2-3 months. The repetitive morbidity. And I think sometime, not sometime, people are not taking the children to the hospital. And one child is suffering from fever, like in every month the child is getting fever, cold and fever, skin infections, and we don't have that knowledge in ground level how we can manage those things. So here, as a policy maker or for advocacy, I think these things needed to be addressed in different forums, and we need to work on that. Thank you, ma'am.
Agree with you, Jasaswini. Yes, definitely there are many areas of malnutrition that directly or indirectly linked to, and we have to we have to hammer on every areas that leads to malnutrition. And thank you for highlighting and bringing these issues. We will definitely work on all these areas. Thank you. Anyone else? Please write. We can unmute you. Otherwise, we are very close to end this series of webinar. Thank you. I would like if Dr. Ashok can give vote of thanks to the audience. Thank you. You are mute.
I'd just like to conclude by thanking all the participants, both speakers today and all the participants who sent in some very good questions. I'd like to thank the MS Swaminathan Research Foundation for sponsoring this two-part webinar. And I think many interesting ideas have come out of this, which I think it's important to pursue. It's great to see some wonderful work being done in these areas, but so much remains to be done, and I'm sure we're all aware of that. And that's all really. Thank you all very much.
So thank you to all the speakers and for both the speakers and Dr. Somya and Dr. Hariharan, though he was not able to present today, he has some very tasks, important tasks other. So yes, we are now closing this meeting. Thank you all, audience.
Thanks, Bharti. Thank you very much.